Hello everyone, good morning. This is Domino Poson, your instructor for NCM 118 this week, week 13. Welcome to week 13. We'll be discussing Unit 5, and in Unit 5 there are two contents for this unit. Unit 5A is care of clients with multi-organ system dysfunction, and Unit 5B, care of clients with endocrine emergencies. For this week, these are your activities for this week. Unit 5 lecture. Make sure you listen to this video, a recorded lecture, and make sure that if you don't understand anything, if you understand something in it, please go to the internet or go to YouTube to search on it. And then Unit 5 additional resources. I put in a link and documents PDF that you will be interested to read, and please view all the videos that is attached to this stream. Next is Unit 5 knowledge check. Make sure you answer the knowledge checks, write it in a separate piece of paper, and then transfer it to the appropriate stream in Google Class. And next one is Unit 5 multiple organ dysfunction VGS game, and the next one is Unit 5 VGS diabetic ketoacidosis pre-simulation and care of a patient experiencing diabetic ketoacidosis VGS game. So both of these are requirement for this week. You have to finish it, and then please review the course outline. In there I put instructions on how to answer and fulfill these requirements. And finally, our semifinals is coming on November 20, starting at 000 to 23:59 for sections A and B. It will be a 100-item exam, and coverage of this exam will be Unit 4 and Unit 5. Now we move on to Unit 5, care of clients with multi-organ system dysfunction. The following are the contents of our discussion for this unit. Unit 5A, first will be shock, second will be systematic inflammatory response syndrome, and the third one will be multiple organ dysfunction. These are life-threatening conditions that a nurse should understand, and the nurse should know how to intervene with this kind of presentations in the emergency department. First off, we will discuss shock. So what is shock? Shock is a widespread, serious reduction of tissue perfusion, lack of oxygen and nutrients that, if prolonged, leads to generalized impairment of cellular functioning. It is a clinical manifestation of inadequate tissue perfusion. So all you need to remember is that shock is the absence of oxygen. It results from a dysfunction of oxygen delivery, transfer, or utilization occurring when the body's demand for oxygen is greater than its supply. In early stages, so there are stages of shock I will discuss later on. In early stages, complex compensatory mechanisms will help alleviate hypoperfused cells, because our body is a machine that adapts to itself. So in the early signs of shock, our body has the capability to adapt. So we have a defense mechanism, and the first stage is the defense mechanism is functional. As the delivery of oxygen continues to be insufficient, cells will deviate from aerobic to anaerobic metabolism in an attempt to meet the body's metabolic demands. So if there's no oxygen, the body will use its own, the cells will use its own machineries to salvage or to perform metabolism. So the ATP and other structures of a cell will be burned in order to continue with the metabolic demands. If unrecognized and without intervention, this progress to death, according to Sweet and Foley. So all of my resources I put in the in-text citation, so you'll know which book I used in this lecture. So in front of you is the pathophysiology of shock. So since we are not more concerned on the pathophysiology, so we're just gonna discuss pathophysiology shortly. So as I've said, shock results from inadequate tissue perfusion that leads to failure of the delivery or the use of oxygen, causing tissue dysfunction. So as you can see here, impaired oxygen use and impaired is the main thing, okay? Is the main thing. So here, so there is impaired cellular metabolism. So why does this occur? It's because of poor tissue perfusion, impaired oxygen use, or impaired glucose use. So these three are ingredient to shock. So we'll discuss about the type of shock so later on, okay? In the presence of hypoxia and inadequate tissue perfusion, cells do not receive oxygen and nutrients or glucose, okay, and are unable to remove metabolic waste products. So think of a machine that cannot, like for example, a car that cannot exhaust its fumes. So cellular damage and eventual death ensues when cellular oxygen demands exceed the tissue's oxygen supply for a sustained time. Please read more about the pathophysiology of shock and understand the pathophysiology of shock in the cellular level. We just don't have time to like discuss in detail. I know this is discussed in your pathophysiology class. So what are the stages of shock? So the stages of shock are the following: uncompensated non-progressive stage. In this stage, the mechanisms or defense mechanisms, the body's defense mechanisms or the compensatory mechanisms are working to maintain a systolic blood pressure within normal limits. So the patient will experience elevated diastolic blood pressure due to peripheral vasoconstriction and narrowing. A narrowing of the blood vessels, decreased urinary output because kidneys retain water early on. So as the body protects itself, it protects from becoming dehydrated. So the body secretes enzymes or hormones that causes the kidneys to retain water. And then there will be an increased respirations to increase oxygen delivery and blow off carbon dioxide in the body. So in the next stage, the progressive or uncompensated stage, compensatory mechanisms can no longer keep up with the degree of hypoperfusion. So there will be a decrease in systolic blood pressure, tachycardia that will be imminent. The patient will appear cool and clammy and exhibit altered LOC or unconsciousness. So reversal may be possible at this stage here. So goals will be to determine and treat the patient immediately. Okay, maybe here we can identify the patient, and then if not, treat the patient here as early as possible. It's better to treat the patient as early as possible. So what is the nurse's responsibility to detect signs and symptoms of shock in its earliest stages? Next is the last one, is the irreversible or the refractory stage. In this stage, this is the final stage of shock. So patient will present to be comatose with severe hypotension and global acidosis, and the patient will have bradycardia, DIC, or disseminated intravascular coagulation. So there will be like blood clots everywhere, and purpura or petechia is present. Kanang nakita mo nang sa dengue nga naay mga pitik-pintik. So petechia or petechia is active sign of death. So knowing this, it will give you a time frame on when to perform your nursing intervention and when to report to the doctor if the patient is experiencing shock. So there are types of shock. The first one is hypovolemic. This is the most common type of shock. This is due to the loss of fluid and or blood. It may be internal or external according to Quellar 2020. So kanang gidunggab ka or blunt trauma, nahulog ka na, so kanang na ang imong body fluids, gawas, blood, or any other. Next one is cardiogenic shock. So it is due to the damage. It is caused by damage to the heart. So it presents as a patient. It presents itself as having ischemia or impairment of tissue perfusion. The next one is distributive. This is the reaction to an allergen. So distributive shock is categorized into three. There is anaphylactic, there is neurogenic, and septic. So anaphylactic shock, a kind of a distributive shock, which is a profound hypersensitivity reaction with a systemic life-threatening antigen-antibody response. Kanang ang allergic og peanut, no? So itong napas Pilipinas, kaya walay allergy. Pag abot na sa Canada or sa US, allergic na sila og peanut, allergic na sila og banana, allergic na sila og flowers, no? Nagka-OA na. So signs and symptoms of anaphylactic reaction is hypotension, altered mental status, hives, urticaria, angioedema, no? ng hupong, shortness of breath, nausea, diarrhea, and in some cases, cardiac arrest. So, kung naa kay anaphylactic shock, so sa Canada o sa US, naa sila epinephrine, no? Blue, nang kaya ito na ay brushing steak, niya ang naa siya ang tumoy kaya ay blue niya, orange. So, kung na ay allergic ang person to anything, magdada sila na mga bata, isod na silang bag, and they're taught how to inject it. So, ini-position nyo, tanawan nyo sa links, additional videos on how to inject a kanang emergency EpiPen. So, blue side up to the sky and the orange is down to the leg. So, ako na siya include, tanawan ninyo ha, ay magkalimutog tanaw. Next one is neurogenic shock associated with acute spinal cord disruption from trauma or spinal anesthesia. Venous return and cardiac output are decreased. So when CO is decreased, so may tabo nimo because shock ka, no? Next one, the last type of distributive shock is septic shock. So the presence of sepsis. We'll talk about sepsis in a separate chapter or unit. And septic is the presence of sepsis with hypotension despite fluid resuscitation. What is sepsis? Sepsis is like an invasion, the body's reaction to an invasion of microorganism. So generalized invasion. So ang kagaw, no, ato na istorya later, and we'll talk about it. And sepsis is very common in the emergency department. Next one, the last type of shock is obstructive. So physical obstruction via tamponade, emboli, or compartment syndrome. So these are the types of shock according to Quillar 2020. So what are the causes of shock? So different causes. One is different types, different causes. It might be blood loss, trauma, allergic reaction, heat stroke, no, nagpainit ka, no, poisoning, severe burns. Why? Kung masunog, good na imong skin, na yung mga electrolyte reactions ana, may tabo, no, kaya na-destroy din ang cells, magawas ang potassium, sodium, uguban pa. Severe infection, no, like sa sepsis, and poisoning. The following the risk factors for shock. Number one is the very young and the old clients. Ako, while working in emergency department, kung ako'y pasyente nga infant or bata, mga bata ang akong priority. Why? And the very old. Why? Because their condition easily slides down the drain. No? So, kita kong bata, automatic assessment, yun na, paswag kong assessment. Mga basta bata. Tanawon din ng LOC, level of consciousness. Kaya mao na importante kayo. Kana magong level of consciousness of behavior sa bata ang presentation niya. Mao na siya early sign of hypoxemia or low blood in the oxygen, low oxygen in the blood. So kung imo nang ma-detect niya kung bata nagduwa, nagkuha na okay ra kadal kang kuyawan, pero kung bata kay sleep ka lang, overly sleepy, mamay nga na natugra na oy ana. So overly sleepy, di lihok na kuyawan ta ana. Next one is the old clients too. They're risk factor for having a shock, no? Tiguwang na niya maupay nas ilaw sa adlaw nangguna man abot sa kuan iyan shock na sila. Now post myocardial infarction MI clients, so kanang yung mga pasyente nga gi MI gi atakis kasing-kasing, tell them that they are at risk for having a shock. So mo na nga kanang kung ari na mo sa Canada na may mga pasyente nga above 40 na, advise na sila nga dili na mag-shovel sa snow kay magkakuan sila cardiovascular problems. Clients with severe dysrhythmia, no? Kanang may mga sakit na istorya na taan ni last time about cardiac problems. So kana sila, clients with adrenocortical dysfunction, history of recent hemorrhage or blood loss, no, they are at risk, and clients with burns, no, and clients with massive or overwhelming infection. So, what are the signs and symptoms of shock? So, weak pulse, no, sa pulse, weak eye, no, rapid shallow breathing, no, kanang weak pulse kanang kasagaran makita sa mga bata o sa mga tiguwang, mura na siya mawala, no, hinay kaayo siya, kasi diri na nimo makuanan, ma-feel. Rapid shallow breathing, cold and clammy skin, bugnaw na sila, no? Na sila padung matay. Pale skin, rapid heart rate, and urine output diminished too little or more. Pila ganito ang normal urine output? 30 ml per hour. So kung less than 30 ml per hour ang urine output sa pasyente, kinahanglan nga unsa man isulti sa doctor. Tell the doctor about it, and the doctor will also order lab works like creatinine to properly evaluate the function of the kidney. And then confusion, no? So confusion is a sign of low oxygen supply or low oxygen concentration in the blood. So mao na nga inyo nang timan-an, no? Okay. So in front of you is a table for nursing assessment for patients with shock, no? So in here, akong gikuha ni siya categorize. Ako gikuha ko ni sa libro ni Quellar 2020 Comprehensive Review for the NCLEX RN Examination 6th edition. So blood pressure. So in patients with cardiogenic shock, blood pressure is less than 90. Okay. For distributive shock, everything is less than 90. I think everything for all the types of shock, you will see that the blood pressure, SBP, or the systolic blood pressure is less than 90. Okay. Next is the heart rate. For cardiogenic shock, greater than 100, and for anaphylactic is greater than 100. Neurogenic shock is less than 60, and septic shock is greater than 100. So pulse. So, for cardiogenic, weak and 30 pulse. Okay, matyo na kasing-kasing, no? Nagpunga-punga na kasing-kasing. Next is for septic, full bounding, widened pulse pressure. And then, for obstructive, mo na ni. Dunay jugular vein distension. Sa'yo na kayo na ang jugular vein distension. Position your patient semifallers. Unya pa linia dito sa kilid. Makita na niyo din. I think ako nang ipakita niyo last time sa cardiovascular. Makita ninyo din. So there are situations nga mo distend ang imuhang vein din. Ang pregnancy, no, mo kuan mo ninyo mga lola mingon nga mabdos ka kay ni kuan man din ni may jugular vein distension. And also pulse paradoxus. Okay, next is assessment of the heart. So, heart sounds are diminished. You can make sure nga maayo na kayo mo minaw sa heart sounds and differentiate it. Okay, na ko discuss din kay madugay ta. Akong expectation is that you know how to listen to heart sounds. And so may mga heart sounds. Now, if you can't answer that question, so you might as well review heart sounds. Naidaghan sa YouTube, no? Next one, sa cardiogenic, na chest pain. So sometimes mid-sternal, sigurang good mid-sternal or upper abdominal pain. Dysrhythmias and decreased cardiac output. Okay? For distributive, anaphylactic shock there is chest pain, decreased CO, cardiac output for all the distributive types of shock. For obstructive, na muffled heart sounds. Kung mo nang nasudlan og kanang tubig inyong dunggan, mo na siya may muffled sound ang inyong madunggan sa pasyente nga obstructive na shock and decreased CO, cardiac output. I think tanan, almost tanan. Pulmonary sa lungs. So when you assess a patient, idolo mo sa pasyente, ang imong assessment is focused. Kung emergency ka, these are emergency cases. So ang imong attack is focus assessment. Asa dapita ang kuan kanang muraog kinabitaw, asa dapita ang naay sakit, no? For example, pasyente kani maabot mangutana judayon ko unsa nahitabo sa pasyente kanus ang nagsugod, unsay mga simptomas niya. Ingos pasyente nga sakit akong dugan, adto ko mag-assess. Okay? Sorry. Next is the lungs, no? Importante kayo nga namoy stethoscope. I don't know kung napakita ba na ako I think napakita na ako sa inyo ang akong stethoscope last time. Na ako pakita sunod, no? Na ay kuha na akong stethoscope echo is an amplifier nya kuha na siya kanang makadungog dayon ko sa unsay mga tingog, no? So cardiogenic shock, there is a respiratory rate of 24. A lot of nurses don't count in full 1 minute sa imuhang respiration mo nang di gyud malangit, no? Kay tag-anon ra 18 man na, sir, no? And then you will hear crackles for patients with cardiogenic shock. Anong na crackles? Because naay gitawag og kay ang kuan man ang cardiovascular ang heart sumpay ra man na siya, di ba? So daghag supma ang fluids maadto sa lungs mo na makadungog mo crackles. For patients with anaphylactic, there is throat tightening, cough, dyspnea, stridor, and wheezing. Okay, and for patients with septic, 24 ang RR for early and 10 less than 10 for late, and there's also crackles for septic shock, and decreased CO for everything for the obstructive, no? Skin. So hikapon nimo pasyente nga na cardiogenic shock, ang yang pale siya, kung puti siya, mura siya bond paper color. Onya pale and cool ang skin. Human sa anaphylactic kay warm, na pruritus, redness, and urticaria. Patient with neurogenic na warm and dry, and for a patient with septic, pink, warm, and flushed. Okay. For a patient with mental status for patients with cardiogenic shock is that there is change in alertness, low oxygen, no? And inipukaw ni mo, can you tell me your first name and last name? Ano siya niya, my name is Anak. So, kibaw na ka, change in OC, no? So una, kay bago pa ko nga nurse, and kita na ako ng pasyente niya, Lord, maluoy ka na ako, change in OC na ni mo, na ni, no? So dapat imong brain, nag-andar gani imong brain, kay mong siga imong mata, ini katubang sa pasyente, no? Imong brain ato, kay ano man, we, as nurses, we have the highest responsibility to determine pag first encounter makaingon nito nga na ni shock, no? So makahatag litag idea sa mga doctor, we can bump them up, no? Kaya sa ER man good, we work with triage nya human kay basin yung pasyente matay ng pasyente na descaled, no? Mangiuna nimo kay katong kuan, walking, talking, and complaining. Sunod sa pasyente with septic shock, there's change in alertness. So perminti katugon ang pasyente nga naay septic shock. Pasyente nga na cardiogenic shock, nakita na dyan kuan kana na-confuse siya, no? Hindi na siya ginahan siya si katug, no? Next is the gastrointestinal and gastrourinary. For patient with distributive anaphylactic, na nausea, vomiting, abdominal cramping, and incontinence. And for septic, na decreased in urinary output. Pilagay itong urinary output, 30. Okay, less than 30, report to your physician. So, management of shock, of patient with shock. First is history. So, history needs to be rapidly collected. So, as a student, okay, mag-agad pa to sa ang papel, no? Mag-anong pa taas kayo. Sa emergency, the reality is emergency, pas kayo na. Triage, they assess patient in 30 seconds. Okay? When the patient is sent to in the place where I work, the emergency department is categorized into several units. So dili lang kay usa, no? daghan kay unit. Each unit is different. So na may A, B, C, D, E, and then RAS, rapid access zone. So A, B, C, D, ang A ana acute. So B is for like babies, C is for mental health, D is for sick patients. Okay, so usually I work in D, and in there dahil sagol-sagol nga klase nga sakit. So ang goal is to bump up the patient, ibutang sa acute kung pasyente na ay mga life-threatening disorders or disease like shock, no? So dito na mo na ma-identify shock, no? Ma-shock then me send na mo sa acute, no? So needs to be rapidly collected. Dili ka maabtan og kuan kanang pipila ka oras si istorya sa imong pasyente, emergency paspas gyud na siya, no? And so history taking namo kay mo kabat ra og kuan kana pila ka minutos, 5 minutes paspas kayo. So your first name and last name, sinhitabo blah 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 blah, no? Wala mi panahon anang 10 years ago, 15 years ago pagkabata nako, no? Next is resuscitation. So there should be adequate oxygenation and circulatory support to correct hypoxia, and inadequate tissue perfusions are essential. So endotracheal intubation and mechanical ventilations are required if needed. Okay, supplemental oxygen should be applied to the patient to increase oxygen delivery. So circulation perfusion, identify fluid or blood loss in hypovolemic or hemorrhagic shock. Active bleeding must be controlled by direct pressure. Common sense. Nagdugo, no, nagsirit ang dugo by direct pressure. Insert large IV. That's IV, okay? This is IV, okay? IV cath, okay? IV cath. Pila man ka unsa mang gauge? 18, no? 18 or 19 kana mo na siya, insert na siya. So as a student kay dili kibalo mo insert, no, sa Pilipinas kay kanang kuan na siya kanang special training. Sa Canada wala na training expected that when you're a nurse kibaw ka insert og IV. So unsaon na nimo? So intraosseous access is a rapid alternative for volume and drug administration. Kausara ko sa kuang kinabuhi as an emergency nurse, nakita og intraosseous, no, katong pasyente nga naay shock, gagmay naman kay dehydrated naman siya. So once a person is dehydrated, the veins collapse. So gagmay na kaayo di niya makita. So the doctor decided to do intraosseous. So sa bone, sa long bone, sa leg. So na sila mura og kanang gun. Ipio na dito, point to the long bone. You will hear like this is traumatic, no? Crack then. Dito sila sa bone sila mag-inject sa medication, no? It's rapid, no, for volume and drug administration. Next is circulation perfusion in hemorrhagic shock. Okay, it says here future control of hemorrhagic may include recombinant factor 7A, hemoglobin-based oxygen carriers, and blood substitutes. Gamit na sa hospital namo. Tranexamic acid has been shown to reduce mortality in patients with trauma and significant risk of ongoing hemorrhage. No? Tranexamic acid prevents hemorrhage. Okay. Circulation and perfusion in cardiogenic shock. Okay, administration of sympathomimetic agents or vasopressors. Mechanical support, mech vents, may be initiated to provide support for failing heart. Next is circulation and perfusion in patients with septic shock. So hypotension should be managed through crystalloid or colloid equivalent fluid at a rate of 30 ml per kilogram. So mo ni ang rate sa inyong fluid, no? 30 ml per kilogram. So if you wonder unsa na pag-compute sa doctor mo ni siya. So if not responsive, give norepinephrine to maintain a MAP of 65 mm mercury. Remember MAP? Ako na itudlo sa kong cardiovascular on sa pagkwenta ang MAP. In here, BP MAP. So appeal ang MAP. Circulation and perfusion of in patients with anaphylactic shock. Aggressive fluid resuscitation to restore volume to the heart. Raise the leg. Na manay pinaka abot pasyente mo na pinaka kuha na mga buhaton. Raise the leg. Epinephrine is administered to increase cardiac output as well. Okay, makusog man ang pump sa blood, na? Pump sa heart. When patient is in profound shock, only the IV infusion of epinephrine is found to be effective for patients with anaphylactic shock. Okay. Circulation and perfusion in obstructive shock. So source must be identified for obstructive shock, and proper critical interventions performed. Example, for patients with pneumothorax, thoracentesis is performed followed by insertion of a chest tube. So this is not new to you. I already discussed thoracentesis before. Pakita natin mo sa mga gamit sa emergency department sa thoracentesis. So the nurse should also monitor for acid-base balance. So metabolic acidosis is corrected by providing adequate oxygenation and perfusion through ventilation, fluids, and medication. If pH is 7.1, administration of bicarbonate, sodium bicarbonates may be needed to correct the pH. So, pasyente nga na siya, dapat duha or more ang inyong IV lines. Okay, maghatag pa din mahatag pa kadriglain, no? Pulse oximetry monitoring. So, ayaw magsugot ng pasyente nga nag-shock, walay IV. Pulse oximetry monitoring, no? Non-invasive, katong clip, tanawin niyo ang oxygen levels sa patient. Less than 90, report to the doctor. CVP for measurement of preload and blood volume. So laboratory and diagnostic testing for patients with shock or shock emergencies. CBC group and screen cross-match. So this is to anticipate for blood transfusion. Serum chemistry panel including glucose, BUN, and creatinine. So chemistry includes your sodium, potassium, chloride, magnesium. Liver function test, your AST, ALT, coagulation profile, your PTT INR, to know if the patient is like bleeding, coagulation. If the source is cardiac, a cardiac panel is evaluated. So part of the cardiac panel is what? Troponin. Very, very important na siya. Troponin. High, kung na inyong hospital mo gamit og high sensitivity troponin. Pilipinas, I don't know kung nabatay HS troponin. Mauta mo sa inyong instructor. Serum lactate levels. Why? Because if patient have shock, take a look at, go back to the previous katong pathophysiology na sa shock. Kung there's no oxygen, the body make use of its own cells. Unya na siya, as a result, lactic acid will be produced. Muna nga taas ng lactic acid. ABG and base deficit levels provide an estimate of the severity of oxygen debt. Chest X-ray also is done for traumatic X-ray of the areas where bleeding occurs. Pelvis, and the lung bones. CT or MRI identify areas of blood loss or possible sources of infection. For MRI, your responsibility is to determine if the patient has any metallic implants in the body. Okay, and then do your 12 lead ECG, do 12 to 18. So nurses do 12 lead ECG, bronchoscopy, paracentesis, gastroscopy, and or endoscopy to determine the source of bleeding. Emergency nursing management. So, imuhang important kayong role is history and physical examination. Physical examination doesn't take long. Pas-pas kayo na mo nag-scan. Emergency, good. Okay? Imo na nga, as an emergency nurse, kinahanglan kay kibawa juga mo assess. No? General appearance evaluated to include LOC, behaviors, anxiety, confusion. These are early signs of inadequate tissue perfusion. And also the color of the skin. Next is appropriate use of tourniquet. That's appropriate use of tourniquet. So natin mga rules and policies on how to use your tourniquet. Placing distally as possible, like 5 cm away from the wound. Okay, don't apply it directly. Avoiding a joint and applying directly to the exposed skin. No, avoiding a joint and applying directly to the exposed skin. Release the tourniquet when it's medically safe, so possibly like about 2 hours, and never applying a tourniquet directly over a foreign object. No? Kutsilyo gataok, dito ni mo gi-apply, so nasamot kamatay ang pasyente. Next is applying supplemental oxygen via nasal prong or non-rebreather mask. So kung kanang kuan lang, mild short of breath, nasal prong. But if ang pasyente kay kuha na gyud siya short of breath, below 90 na ang saturation, kuha na gyud na siya non-rebreather. And BP monitoring, so less than 90 is BP, reported to the doctor. Central and peripheral pulses, no? Imong kuha ng mga pulses, na puppy pulses, weak 30 pulse, itong ma-observe na niya. Capillary refill to assess perfusion. Temperature, breath sounds, heart tones, and bowel sounds should be auscultated. Fluids, blood, and blood products may be required for volume replacement. If large amount is required, massive transfusion protocol. I don't know kung naba mo yung massive transfusion protocol diha. Sa akong gitrabahoan kinami gitawag massive transfusion protocol, and mura na siya code blue sad, no? So sa may tabuan na is that it will if a massive blood transfusion protocol is triggered, ang tanan ng mga portering services kay mo prioritize sa massive blood coming from laboratory to emergency department, and also vasopressors. What are the complications of shock? So early complication of shock is tachycardia, hypotension, weakened peripheral pulses, restlessness, agitation, confusion, pale, cool, clammy skin, and decreased urine output less than 30 ml per hour. For severe, there will be MODS, multiple organ dysfunction, renal failure, pleural effusion, and there is respiratory distress, renal failure, and also death. So you have to take care of a patient with shock with all your diligence and carrying all your knowledge in nursing. Knowledge check for a patient with shock. This is number one. Knowledge check number one. Which of the following symptoms are signs of inadequate tissue perfusion? Except A, LOC, B, anxiety, C, confusion, and D, color of the eyes. Please write your answer on a separate sheet and then transfer it later in the streams for Unit 5 Knowledge Check. Next topic is systematic inflammatory response. So SIRS, so it's a systematic inflammatory response to a variety of insults, including infection, ischemia, infarction, and injury. So characteristics. So SIRS is characterized by at least two of the following: fever, edema, hypotension, tachycardia, impaired oxygenation, and elevated WBC count. So there are triggering mechanisms for SIRS. So SIRS na kuya na siya, life-threatening na ganyan siya. So systemic inflammation as a response to variety of insults in the body. It's a body's response. Triggering mechanisms is abscess formation, endotoxin, global perfusion deficits. Global perfusion deficits is your post-cardiac resuscitation patients in a shock state. Okay, ischemic or necrotic tissue. This is like the pancreatitis, vascular disease, or your MI patients. Mechanical tissue trauma. These are the burns, cross injuries, surgical procedures, microbial invasion, bacteria, viruses, fungi, parasites, and regional perfusion deficits. Your distal perfusion deficits. And also, this is your pathophysiology of SIRS. So it starts with an infection, and then body's response is inflammation is body's response, right? Remember? Next, if treatment is successful, or the body successfully contain or kill the bacteria inside our body, then there will be resolution. There will be host recovery. But if not, there will be progressive inflammatory response in uncontained infection secondary injury. And then there's immune suppression, reduced infection containment, endothelial damage, barrier dysfunction, katong blood-brain barrier, mubag na ng utok, epithelial dysfunction, and barrier dysfunction. So there will be multiple organ failure, hypoxia, apoptosis, and then irreversible changes like the death of the host. No, so SIRS is the cause of multiple organ dysfunction. Natong discuss later. So it is important to determine if SIRS is caused by an infection, as early treatment is crucial to deter sepsis from advancing to severe sepsis or septic shock. So kinahanglan may bawaan in order to know which kind of antibiotics that we need to, what type of infection. No, a useful biomarker to check is serum procalcitonin (PCT) levels, as well as other diagnostic criteria. Supportive measures for patients with SIRS: mechanical ventilation, no? That is to support the heart and the lungs. Aggressive fluid resuscitation to prevent dehydration. Nutritional support like proteins and cardiac proteins, carbohydrates, and other vitamins, and cardiac pharmacology. And also your broad spectrum antibiotics that can assist in the to survive the acute hypoperfusion state of SIRS. Many patients progress to multiple organ dysfunction syndrome, MODS. That's why I said SIRS is one of the causes of multiple organ dysfunction syndrome, or MODS. Systemic inflammatory response. We are still here. Nursing and collaborative management, SIRS and MODS. Kay kuha naman sila ang SIRS causes MODS man, so usa rin ilang nursing intervention. So prevention and treatment of infection, aggressive infection control, strict asepsis. So most possibly kung namin pasyente ingin ani padana diretso sa ICU level of care ni sila. Di ni siya sa simple nga ER lang. Acute, ano ni butang sa acute sa ER, send ni sila sa paspason yun naman ipasend sa ICU. Prevention and treatment of infection, as I've said, aggressive infection control, strict aseptic technique, daily assessment of the need for invasive lines, katong ganang mga IV, NG tube, kaning oral nga tube, o tanang mga, especially IV, no? Kung kinahanglanon ba. If infection is suspected, intervention to control the source is implemented. So first, we need to do cultures. Doctor ordered in cultures to determine which microorganism causes the infection. Antibiotics. So, for example, ang culture takes 3 days to result. So, may na din ang microorganism that causes the thing, causes the infection, i-modify na din ang antibiotics. But antibiotics can be started even if the culture has not resulted. And then remove necrotic tissue. So nakita nga sa part sa lawas na baroy necrotic. So luyo, no, na isamad, most makana siya kagaran sa luyo na isamad nya ni baho na necrotic na tangtangong, then surgery is done to remove that immediately before mukatag na sad ang source of infection. That is to treat the source of infection. Once specific organism is identified, therapy should be modified. Pulmonary management, so early ambulation. So in ICU, i-refer din nila sa PTOT aron makalakaw-lakaw ni sila. Early ambulation will promote good pulmonary pulmonary management. Maintenance of tissue oxygenation, sedation. Why sedate na itong pasyente? Why taga itong mechanical vent or analgesia or induced paralysis and rest? This is to decrease oxygen demand. Muna ipadana nila sa ICU, i-sedate ni sila, no? Aron maka-relax ang ilang lawas. Kay anxious man nga pasyente, remember? Anxious ni nga ang pasyente nga na mga inani. Maintaining normal levels of hemoglobin. So mo nang andamon gito nimo dayon ang mga cross matching, group and screen, EBO compatibility, no? Aron andam na siya, gi-order na siya daron if there's a need to kung ubos gani ang levels of hemoglobin, 16 ana transfusion dayon ng doktor. Yan wala na, you should not be a cause of delay. Okay? PaO2 is 80 to 100 millimeters mercury. So for patients with SIRS, if not detected early, prognosis is very poor for this patient. So mortality is high at 70 to 80% if there's an involvement of 3 or more organs. So imong pasyente gani ngayon ani SIRS na dapat kanang i-consider na nato ang likelihood of likelihood of DNR or no CPR, no? Inon ang doktor. So as nurses, dili ta ka pwede nga makatana sa pasyente or sa family unsa man ni, if the patient can decide of their own o stop na ang beating sa heart unsay buhaton, itayo na as nurses. We can be a witness, but ang doktor may mukha na. So may role nimo to encourage to follow up the doctor kung unsay status sa pasyente. Some full code. So if there's full code, like resuscitation should be done, CPR should be done. But if no CPR or DNR, so mo na siya, consider na siya, no? Especially nga taas kayo yung mortality rate niya. A critical component of the nursing role is vigilant assessment. Okay? Which kay fourth year naman mo, ako nang gi-expect nga kibaw na gid mo assess, no? Mo nay importante kaayo, no? Okay. Kibaw mo sa types of assessment, di ba? Na focus assessment, whole body assessment, na systems assessment, no? ER focus assessment ang gamit. An ongoing monitoring to detect early signs of deterioration or organ dysfunction. So we're still in the nursing and collaborative management for SIRS and MODS. Nutritional metabolic needs. The goal of nutritional support is to preserve organ function. Early and optimal nutrition decreases morbidity and mortality rates with SIRS and MODS. No, sufficient amount of kanang protein, carbohydrates, and amino acids should be given. If patient cannot tolerate oral intake, the safest way, safest way is for patient to eat. But if patient cannot eat, no, kuyaw na nimo pakanon kay mato na sa lungs, masuka pa siya, magkuha na pasyente, magka-pneumonia, aspiration pneumonia. So it should be given via the enteral route. So it is as a nurse in Canada or in the United States, it's expected of you, or maybe in the Philippines, expected of you, you know how to insert a nasogastric or NG tube. So naman sa inyo hang si Kanier. So din kani siya mo siya gitawag na mo og core pack, no? Sa Canada mo na siya gitawag og core pack. So mo ni ang amuhang NG tube. Napod mi katong regular, napod mi mas ginahan ko ani. This is used for feeding, okay? So na siya guide wire right here. Guide wire kinam sa OR, guide wire. Wala na sa metal nga guide wire. Nya kinahanglan ni siya training when you insert this kay this could puncture the lungs. Okay? So, ang nakanindot niya kay self-lubricating na ni siya. So, how to measure self-lubricating? Mo ni siya humulog tubig. Hindi na kami nanglan at itong mga jelly. Humulog din mong tubig niya. Flush na din mong tubig din, he. Automatic na siya. Makuha na siya. Lubricate. So, sa may mo pag insert, pag measure. So, measure sa tip of the nose to here. Unya, dinhi sa imuhang kuan. Dinisa ko yung part. Ang mga klase ng nurse up to here. Okay? So, naa siya number. I don't know kung makita mo yung number. So, 55. No, na number siya, 55. So, imo nang timan-an, 55. Nag-insert name mo sa imong ilong. So, sa mga pahangaron or pawan. So, lang, slightly kanang nakaduko. Nya insert nimo ni nag-insert nimo ana inon yung pasyente nga to swallow. If dili ka swallow ang pasyente dito ra kag sod, no? So sod nimo ana kutob ka sa 55 ahaton niya butangan din nimo diri og kanang plaster. Butangan mo plaster imo na dayon ng saan man sa Philippines, in Canada ang gitrabuhan wala na mi atong submerge nimo tubig mag-inject ka o mag-withdraw ka o something mo na saan na mo isirado na mo unya maghuwat na lang mi og mag-order mi og x-ray, no? Chest x-ray to confirm on say purpose to confirm the placement of the NG tube or the core pack. Kani siya. Pwede ni siya for feeding, no? Kani. Indot ni siya. Okay? Limpyo ni ha. Wala ni gamit sa pasyente. Gihugasan no kaya ang gamiton sa kanin. Limpyo ni. I was trained mo ni first time nga gi-train ko, manilang hatag na ko. Masun yung gamit to teach other nurses how to insert a core pack. Now, if not tolerated via enteral nutrition, pwede gamitan og TPN, total parenteral nutrition, no, ato gamiton sa IV or PICC lines. No, search PICC lines sa YouTube. Mabaw mo sa PICC line, PICC lines. Use insulin protocol and control blood sugar at less than 10 millimoles. So normal blood sugar is 4 to 10 millimole. Pila man na sa kuan sa inyo sa Philippines, kay I think lahi ang gamit sa Philippines, may mg per L. Kuan na siya 80 to 120. So pasyente nga kuan kanang na ISIRS kinahanglan maintain imong blood sugar, no? Support of failing organs. Support of failing organs is the goal of the therapy. So aron dili magka kuan MODS or multiple DIC treated appropriately, kanang muhang disseminated intravascular coagulation and renal failure. Renal failure here may require dialysis. Hindi na magawa sa inyong portable dialysis machine. No? Continuous renal replacement therapy or CRRT is tolerated better than hemodialysis. Withdrawal of life support may need to be considered when everything fails. No? It is important to ensure that advance directives are clearly indicated and that the nurse follows the patient's wishes regarding the end of life care. No? Yes, Canada, we have to be sa Canada kay kon kami ana kanang tawag na concern kami ana kay what kay ba na dinay kon ng pasyente na siya advanced directives. So without delay, we'll continue our discussion to multi-organ dysfunction syndrome or MODS. This MODS is the progressive dysfunction of more than one organ in patients who are critically ill or injured. Okay, causes is extensive burns, trauma, cardiorespiratory failure, multiple blood transfusions, and systemic infection. This systemic infection is the most common and leading, and MODS, multi-organ dysfunction syndrome, is the leading cause of death in ICU. So, pathogenesis. So, normally the human body responds to illness and injury by activating compensatory mechanism to adjust to injury. Responses include increased heart rate, contractility, increased cardiac output, and oxygen consumption, increased oxygen consumption. The neurologic and endocrine system respond by releasing mediators to address injury. No, na injury, catecholamines, cortisol, antidiuretic hormones, growth hormones, and glucagon will be produced in order to help in the imbalance in the experience of pasyente. So normally that's what happened. So this occurs within 3 to 5 days and after the injury or the insult, and diminish within 7 to 10 days. Normally mawala na siya. And for some reasons, some patients some patients does not respond, their symptoms does not diminish, and tachycardia, fever, and a state of hypermetabolism continues, and they need help. So cause of MODS is an uncontrolled systemic inflammatory response, or SIRS, an effect of multiple mediator systems known as a systemic inflammatory response syndrome. Initially, this uncontrolled SIRS is manifested by the following: a temperature of greater than 38 or less than 36, heart rate greater than 90 beats per minute, respirations greater than 20. Now, ipon ang respirations, dili tag-anon, okay? PaCO2 less than 32 millimeters mercury, and WBC is greater than 12,000 millimeters cube or less than 4,000 millimeters cube, or more than 10% immature bands or forms. So these are the clinical manifestation of multi-organ dysfunction syndrome. Ang gibutan ni siya for in order of systems. So in CNS, there will be altered LOC, heart rate less than 54 or greater than 100, and MAP is less than 45 millimeters mercury. In my previous discussion, we learned how to compute MAP. So mean PA is less or greater than 15 millimeters mercury, and cardiac output is less than 4 or greater than 8 liters per minute. The heart, also may reaction sa heart, ang CVP is less than 2 or greater than 6 millimeters mercury. The skin is cold and pale. There are weak pulses. Urine output is less than 30 ml per hour and irregular rhythm. Remember regular and irregular rhythm? Na sa atong previous lecture. Review that if you forgot. Next one is pulmonary, the lungs. Respiration is less than 5, kana makuyawan na tayo, or greater than 49 beats per minute. Oxygen saturation is less than 90 millimeters mercury. Oh no, not 90%. No, so yung pasyente less than 90 na gina report. Don't ignore report. Okay? pH is less than 7.35 or greater than 7.45. PaCO2 less than 35 or greater than 45 millimeters mercury. And bicarbonate ACO3 less than 22 or greater than 26 millimeters mercury. The kidney. So a nurse will observe that in patients with MODS, urine output is less than 30 ml per hour. No? So serum BUN is greater than 100 milligrams per DL, and serum creatinine is greater than 3.5 milligrams per DL. Okay, wala naman yung function ng kidney. GI. So there's decreased or absent bowel sounds. So assess gilin mo sa bowel sounds and listen to the bowel sounds of the patient. All 4 quadrants. Start from the right, lower right, top to upper right, then on the opposite, left upper, and then lower. Okay? Abdominal distension. So yung hikapon ang tiyan, no? Asay mag-una, percussion or palpation na dapat inyo nang ibaw mo ana, okay? Diarrhea or constipation, and heme positive stools. So na ay dugo sa ilahang stools. Liver, there's jaundice, no? Serum bilirubin of greater than 6 milligram. PTT is greater than 4 seconds over control in the absence of systemic anticoagulation. Hematologic, WBC is less than 1,000 and platelets less than 20,000, and hematocrit is less than 20%. Immune system. So ang bago ring NCLEX, I have to share to you the new generation NCLEX. Dili na mo patag-anon kung pila ang normal na kuan, platelet, normal hematocrit, so dili mo sag-uwan na tagaan na mo sa normal values, no? Yang ilang pangutanan ninyo is what to do in the clinical setting. Before, they said that NCLEX is a theoretical test. Right now, it's what you do. I-test ka sa unsay mong buhaton na clinical area. Okay. Now, let's move on to immune system. So, there will be generalized immune system depression. No? So, yung pasyente, di na pwede ni mong muna taas kayo ang level of kanang aseptic technique for this kind of patient. Kay, kung man sila immunocompromised. So what are the at risk? Who are at risk for multi-organ dysfunction syndrome? Number 1 is the patients with systemic infection, especially gram-negative sepsis and extensive burns. Okay, muna nga kuan. Ayaw mo pasok. And organ failure, especially kidneys, pancreatitis, no? May pancreatitis, papirahin na dahil na hypovolemia, cardiogenic shock, human immunodeficiency virus. Yeah. At the end, sa Canada nami o sa US siguro nami na ay medication that suppresses the prep niya nga tambal nga imno nila niya magkuha sila mag multiple sex partner de mag-engage sila og sexual intercourse with other patients, with other people, especially in the clubs mo nilang tumaron pre-ep, no? So this the later stage of the human immunodeficiency virus infection, multiple organ dysfunction. Aspiration, and people who are was aspirated and having multiple blood transfusion are at risk for MODS, and also patients with trauma. Now, MODS, the mortality is high for this patient. Patients can recover actually, and recover depends on the severity of the illness or injury, underlying organ reserve, the speed of instituting effective treatment, many rules and nerves to detect, and the adequacy of treatment, and the number of and severity of subsequent injuries and complications. If treatment is unsuccessful, death usually occurs, remember this, 21 and 28 days after the initial insult. Sorry. So what are the medical treatment for patients with MODS? Sorry. One is identifying the underlying cause, okay? Say cause, unsa ni siya, sinahitabo ni, unsa man ni, bleeding ba, infection ba, maintaining tissue oxygenation, provide oxygen via nasal prong, provide nutritional support, makaon ang pasyente, consider ato ikon yung nutritionist tagaan siya saktong pagkaon, kung dili siya makaon adto sa NG tube, kung di makaagi sa NG tube, TPN, total parenteral nutrition. Avoiding additional complications, prevent infection, and supporting individual organs by means of mechanical ventilation, dialysis, transfusion. Dialysis, it cleanses the blood, aron nindot ang perfusion ngadto sa mga organs, and transfusion of blood products and pharmacologic support is required. And also aggressive diagnostics to identify the organism that caused infection. Blood culture, urine culture, tanang culture, iconic process na siya. You have to remember that culture results in 3 days. So dapat gihimo na siya as early as possible. Abot pa lang sa ER. Adequate airway support by oxygen administration and make vent as needed. BP, cardiac output, and fluid volume status may be supported with administration of crystalloids, inotropes such as dobutamine, and vasopressors such as dopamine. Still in the multi-organ dysfunction syndrome, nutritional supplementation of carbohydrates, proteins, and amino acids is provided via IV or enteral feedings. Also changing central lines every 72 hours, especially katong gi-insert sa for example gikuha sa EMS, sa ambulance, especially kadto ilisa na siya. Patients who are intubated should be weaned and extubated as expeditiously as fast as you can, as tolerated to reduce the risk of infection. Okay, direct access man na invasive man na ang intubation. Kita na mo pasyente nga gi-intubate na after sila for pneumonia, okay, direct access na sila. Dialysis may be used as a supportive measure for renal insufficiency and failure. Kay aron di matay himuhang kidney, so ikaw na lang kay di naman kimatyo naman siya, di naman siya maka-filter, so hemodialysis na lang pasyente. Kita mo portable hemodialysis, dadon na siya. Administration of blood and blood products, albumin, platelets, and fresh frozen plasma to replace the lost blood during trauma or bleeding. Pharmacologic support include antibiotics, antioxidants, antiprostaglandins, antihistamines, and corticosteroids. I-search ning tanang mga tambalang inyo nakita karon, all this medication aron mahibaw mo kung unsay ani sila, aron mahibaw mo kung unsay nganong panghatag ni sila. For sure, corticosteroids hatag to prevent inflammation, right? Kaya common ang cause of multi-organ dysfunction syndrome is a generalized inflammation, or the SIRS, right? Sigres is a new medication under miscellaneous class drug classification, being currently used for the treatment of sepsis in MODS. Now we proceed to the nursing responsibilities. So the multi-system yapunako CNS is assess of level of consciousness per Glasgow Coma Scale. So Glasgow Coma Scale, put that into your heart, aron kung pangutan pila may GCS score ano niya, may 14, 10 or 15, no? So buhaton kung 10 o buhaton kung 8, no? So in the link below kay na ako'y link for Glasgow Coma Scale. Please watch it. Next is pulmonary. Observe for and report the following: use of accessory muscles, no? No? Basta ang mga intercostal spaces and intercostal muscle maapil na og ginhawa. Use discolored sputum, no? Nanay blood tinged sputum, no? Wheezes, crackles, rhonchi. Make sure you can properly identify these lung sounds. Poor capillary refill, decreased O2 saturation, abnormal ABG values, and provide emergent airway support as needed. For cardiovascular, observe for and report changes in the following: heart rate less than 60, no? Automatic dyna report. Blood pressure systolic less than 90, report. PAP, CO or cardiac output, and cardiac index and CVP, no? Report. Next is cardiovascular. What are your intervention? So nursing responsibilities is for observe for cold, pale skin, diminished pulses, decreased urine output, dysrhythmias, myocardial ischemia, elevated isoenzymes, and elevated troponins. No, you know what troponins is? No, so getong troponin is an enzyme that is produced when there is injury to the heart, specific to the heart. No, na kay high sensitivity troponin. Kuha na siya, pinaka-sensitive na siya, ma-detect ang sa HS troponin 2 hours, even 2 hours after injury to the heart. Gastrointestinal, observe for the following: decreased bowel sound, abdominal distension, no? Diarrhea, constipation or impaction, jaundice, ascites. So kaning constipation kung naipasakit multi-organ dysfunction ang pasyente, tagaan jud din ng stool softener. Automatic gid na kay they want bacteria and other byproducts of digestion, metabolism out of the body. Jaundice, ascites, and observe for lab results for increased ammonia, no? Ammonia mao nay ato ang kuhaon when we mo nang tagaan sila stool softener ang mawagtang na siya. Decreased plasma proteins, decreased clotting factors. Asam na makitaan ato na sa inyong blood test, and increased liver enzymes too. GU, genitourinary. Observe for any changes in urine output, color, odor, and observe laboratory results for increased BUN and creatinine levels. Knowledge check. Which of the following is the at risk population for MODS? This is question number 2. A, extensive burns. B, pregnancy. C, pancreatitis. D, HIV. Next one, number 3. A common clinical signs of MODS is acute respiratory failure. True. A, true. B, false. C, maybe. D, I don't know. Okay, there's no points for C and D. Number 4, dialysis is a treatment for MODS. So, ang sama ito na istorya man tayo dialysis, pero unsam ni siya, no, sa pasyente nga na MODS. A, true. B, false. C, maybe. D, I don't know. So, if you don't know, don't answer that one. Ilananta mo, no? Balik sa akong discussion. Number 5. Nutritional support for the patients in MODS is provided by frequent high-fat feeding. A, true. B, false. Kanaw dekhang fat. Aron ma-fat ang pasyente. Mutigok mo. Maybe, and I don't know. Encephalopathy. Number 6. Encephalopathy. Hubag ang utok. Mention ko na sa. I think ako nang gi-mention. Is a clinical manifestations of MODS. Saman. A, true. B, false. C, maybe. D, I don't know. Number 7. Fluid volume excess is a problem with MODS. Fluid volume excess. No, nalaghan ang kuan. Mao man problema sa pasyente with gitawag og MODS. A true, B false, C maybe, D I don't know. So this is the end of Unit 5A, and then we'll proceed with Unit 5B. Please pause this video and take a rest. Get a 15-minute break, eat something, because your brain will not work if there's no sugar in it, okay? So we'll be discussing sugar after this. Sugar and, blood sugar after this in Unit 5B. Please take a break, okay? 15 minutes. I guess your 15-minute break is done, so we proceed with Unit 5B, care appliance with endocrine emergencies. This topic contains the following: hypoglycemia, hyperglycemia, DKA, and hyperosmolar non-ketotic syndrome. So when we talk about hyperglycemia, we also talk about diabetes mellitus. So DM is a disorder of the endocrine system that causes alterations in glucose metabolism. So there are two types of DM, type 1 and type 2. I'll talk about that later. When we talk about DM, we don't skip talking about the pancreas and its enzymes. So the pancreas has both endocrine and exocrine function. This pancreas releases juice full of enzymes and other components that helps with the process of digestion. It also adjusts pH of the components of the duodenum, so pancreatic enzyme can work efficiently. So our small intestine, remember duodenum is a part of the small intestine, is the first part actually. So we have the duodenum, jejunum, and ileum. Proteases, amylase, and lipases, these are pancreatic enzymes that facilitates the breakdown of protein, starches, and fats. The islets of Langerhans contains primary endocrine cells referred to as alpha, beta, and delta cells. So these are the cells I'm talking about that causes a lack of the production of the enzymes in these cells causes diabetes mellitus. So let's see. Alpha produces glucagon, which helps maintain normal blood sugar levels through the breakdown of glycogen. We call it glycogenolysis, and the formation of glycogen from fats and proteins. We call it gluconeogenesis. Beta cells, which is the focus of today's discussion, is beta cells produce as insulin, which is the key that allows cells to be permeable to glucose and friends. Okay, glucose, amino acids, potassium, magnesium, and phosphate. Therefore, if you give insulin to a patient, you expect that blood sugar levels will go down, potassium will go down, magnesium will go down, and phosphate will go down as well. So delta cells secretes somatostatin, which inhibits growth hormone, thyroid stimulating hormone, insulin, glucagon, and other GI hormones. In effect, they causes hyperglycemia. Now, insulin that is produced in the beta cells assists in protein, fat, and carbohydrate metabolism and in the formation of new proteins. Patients who are in insulin deficient have developed depleted protein and decreased glucose in muscle cells. Mao na nga makita nimo kung absence of insulin will cause a person to have diabetes mellitus. Early on, makita nimo pasyente nga mudaot sila, no? An abnormal release of stored body fat occurs because of a shift from carbohydrate to fat metabolism. Okay? Ketone, so ang body nagtuo nga wala nay sugar sa lawas, kaya di man makasud sa cell, ang iyang buhaton iyan na lang i-metabolize ang fat. Now, if you metabolize fat, there could be a production of ketone, okay, which results from the metabolisms of fats, of course. And if left untreated, it results in ketoacidosis and coma. We'll talk about them later. So, the types of insulin, we have type 1 and type 2. Type 1 is an autoimmune process. There is an autoimmune process that causes islet cell antibodies associated with an absolute lack of insulin, and typical onset is before the age of 30. So patients with type 1 DM are often at their expected ideal body weight or below. Okay, these people who have type 1 diabetes requires insulin. Type 2, there is a relative insulin deficiency and absence of circulating islet cell antibodies. Occurs in obese people older than 40 years of age. Proper diet, exercise, and oral hypoglycemic agents may be used to manage DM type 2. After 5 years, this is the sad fact, after 5 years or more, insulin may be required to these patients. Now, what causes diabetes? Causes is number one, genetics are the following. Genetics is the main one. So if your mom and dad has diabetes, and you make sure you live a healthy lifestyle because you might have one. Diseases or trauma of the pancreas, infections, and as well as drugs. There are drugs that causes hyperglycemia. Now, prevalence. 16 million of Americans are diagnosed with DM. How about the Philippines? 4 million according to CODIS at the Philippine National Authority, PNA. This is a government website, so this is not a fake news, okay? 4 million Filipinos are diagnosed with diabetes, and in Canada, about 5.7 million are diagnosed with DM, especially type 2. Now, what are the complications of diabetes? Complications are chronic hyperglycemia. So, sige na nagtaas ang imuhang blood sugar levels. So, if pero sa taas imong blood sugar levels, it could cause organ failures like the kidneys, mabuta ka, eyes, magka-diabetic ulcers ka, no? Alterations in metabolism, vascular and neuropathic alterations. Diabetes is the leading cause of end-stage renal failure and blindness in adults. So, mao na nga, blindness in adults, mao na nga magbantay jud ka kung na kay diabetes, okay? So, treatment for type 1 is regular sugar monitoring. The problem is they don't want to, especially during the first few months after diagnosis or a new diagnosed patient, they don't want to monitor the blood sugar level. They feel gross and they don't like it. They don't want to participate. They're in denial. Okay, being diagnosed with diabetes, which is a lifelong disorder, is difficult to accept. So that's why they don't want to participate, and they are in denial. They don't want to know. They don't want to know. They don't want to what they call this, accept the fact that they have type 1 diabetes. Maintain diabetic diet. So what are diabetic diets? So these are foods that are less in sugar, no? Yeah, go again siya properly what they call this, properly appropriated by a dietitian. Type 2 diabetes is treatment is to maintain ideal body weight through diet and exercise. So, consulta ka with a dietitian or nutritionist, and they will identify your ideal body weight. Regular monitoring of blood glucose, administer oral sulfonylureas, administer biguanides, we call it metformin, most common form of oral anti-hyperglycemics, and to reduce blood glucose production by the liver. So administer thiazolidinediones, so that meglitinides, dipeptyl peptidase, 4-alpha glucosidase, incretin mimetics. So there's also what we call gestational diabetes. It occurs when you're pregnant, right? So because someone asked me, a pregnant colleague asked me, Domino, do I have to monitor my blood sugar level while I'm pregnant? I said, of course, because you don't know if you will have gestational diabetes, right? So for gestational diabetes, you have to regularly monitor blood sugar levels, blood glucose levels, and maintain weight through diet and exercise. And most oral diabetic medications are contraindicated in pregnancy. And the only thing that you can give in pregnant women is insulin if diet and exercise fail to control the blood glucose levels. Nursing intervention, explain to the patient. So you have to do a lot of explanation to the patient. And if it's early, patient doesn't want to learn, doesn't want to recognize the presence of the disease. Okay? Kung man sa sakit mo sa inulan na kay DM because wala na may tambal sa diabetes mellitus, right? So disease, explain to the patient the disease and the importance of maintaining normal blood sugar levels. So normal blood sugar levels is 80 to 120 or 4 to 10 millimoles. Blood glucose monitoring, so saan pag prick, I'm sure kibaw mo ana, no? It's expected of you to know. So ako sa nang include sa kuan, tawag ani, include na ko sa link. Diet and food choices, encourage exercise, diet and food choices, and they have to be careful, no? And they have to exercise as well. Discuss coping skills to reduce anxiety, no? Wrong na ang gibutan niya. Teach self-injection of insulin. It's very important that a patient knows how to inject insulin because this is a lifelong disease. Smoking cessation, self-care, MPL, no? Yang mimpiuhan. Prevention of complications like diabetic foot, importance of daily medications, hypoglycemia signs and interventions, signs and symptoms of hyperglycemia, management of hyperglycemia, change in medication or dosage, increase in regular exercise, more careful food intake, meal planning, increase in the number of finger sticks and discussion with doctor, nursing practitioners, or physician assistants. Glucagon injections for hyperglycemic. Now, what are the signs and symptoms of hyperglycemia? So the signs and symptoms of hyperglycemia are the following. So first is fatigue. No more essential. Kuan. Next is headache, blurry vision, and dry, itchy skin. So patient, these are the signs and symptoms you have to take note. Now we'll talk about hypoglycemia. So acute hypoglycemia occurs when the blood sugar or glucose levels drop rapidly. So without enough glucose, brain cells cannot use adenosine triphosphate, your ATP, for energy, which causes cerebral dysfunction. So dili mo andar ang utok, no? So this process causes sympathetic nervous stimulation and increased levels of epinephrine, glucagon, growth hormone, cortisol, and adenocorticotropic hormone. These hormones suppress the secretion of insulin and act to increase blood sugar levels by gluconeogenesis and glucolysis. Epinephrine and cortisol also inhibit glucose use in muscles. So, what are the causes? So the causes of hypoglycemia are the following: adrenal insufficiency, alcohol ingestion, oral anti-hyperglycemic agents, and the use of insulin. These are common causes of hypoglycemia. So clinical manifestations. So when you see these manifestations, make sure you have to check what? Okay, you have to check the sixth, we call it the sixth vital signs. Blood sugar, how to check blood sugar. So if you see this patient who is sweating and having tremors and sweating, okay, blurred vision, okay, hunger and weakness, behavior changes and confusion, anxiety, paresthesias, and poor coordination, ng pasyente na tingling sensation ako, okay, slurred speech, headache, palpitation, nausea, seizures, stupor, and coma, no? Ako'y pasyente sa una, assign pa ko sa trabaho po ko sa clinical resource team. Ako'y pasyente, kitawag ko, Domino, tawag siya. Domino, Canadian man. Domino, come over, help me. I'm so tired. What? So akong gidulong pasyente, when I approached the patient, I saw him like almost taking a shower of like sweat. What what's wrong with you? I thought the patient has a stroke. Then later on, he said, my vision is blurry, and I'm so weak, and I think I'm gonna pass out. Ang pasyente, no? So no taon ko, so dalit na ko kuha og kuan blood sugar, and I found out ang iyang blood sugar level is 1.9. So when naging ang level 1.9, critical na ang levels, and you have to give the patient something, no? So ako na-discuss niya later on kung sa ihatag sa patient nga nag-hypoglycemia, no? Okay. Sorry. So next is severe or prolonged hypoglycemia can cause brain damage. So you have to make sure nga inyo hada yung tagaan o immediate attention ng mga pasyente nga ay hypoglycemia. Okay? So interventions: identify patients at risk for hypoglycemic episodes and monitor for manifestation of hypoglycemia. So if the patient has a blood glucose level above 80 milligrams per dl or 4.4 millimole with symptoms, administer a diet drink and blood glucose level rechecked in 15 minutes. Why? Even if it's a diet Coke or diet something, it has a little bit of glucose, and then recheck in 15 minutes. This is what the book says, but in our hospital we don't use this. We jump into the next one. We give half a cup of apple juice, but it depends though, because other hospitals have different protocols. We have in our hospital we have a glycemic protocol, hypoglycemic protocol. Kung ubos 3 or 4, matagdayin mi og 1 cup apple juice, check in 15 minutes blood sugar recheck, and then kung ubos gihapon, give another apple juice and then recheck in 15 minutes, and then after 15 minutes ubos gihapon, hatag na siglaing apple juice and check after 15 minutes. Sorry, last na ni mga check. After that, tawag na ka sa doctor and prepare D50. No, kung ano pasyente tawag na kung ano pasyente, depende kung ako na istorya on later. Okay, so if the patient here sa libro, if the patient's blood glucose level has dropped below 80 milligrams per dl, so kaning listahan natay card in blood glucose indicator card. Kay sa Philippines, I believe ang atong gamit kay milligrams per deciliter. In Canada, what we use is the millimole per liter. So below 80, that is below what, 4.4, no? So blood glucose has dropped below 80 at recheck. Assess the patient's ability to swallow and administer FACs. FACs are fast-acting carbohydrates. So fast-acting carbohydrates are the following for sa among hospital na agimi perminti apple juice, orange juice, cranberry juice. So sa fridge naka-prepare gyud na siya. So ang ako yung suggestion is to give 4 ounces or 1/2 cup of apple juice. And why not orange juice, sir? Because orange juice has potassium. Kung ang pasyente kay naay problems sa kidney, makadaot ang potassium. So mao na ang apple juice ang akong safe. Kung wala apple juice, give cranberry juice or skim milk. Now, what are the interventions for hypoglycemia? If the patient has a blood glucose level of less than 60 milligrams per dl, assess ability to swallow and immediately administer FACs. Assess blood glucose every 15 minutes until blood glucose level is greater than 70 milligrams per dl or 4 millimole, then give snack. If patient is not NPO, and that patient can tolerate and swallow. If the patient is unable to swallow or is NPO or is unresponsive, administer glucagon IM or SC or dextrose D50 via IV. So manginahanglan kay dako nga kay ko ni siya murag 50 siguro ni siya 50 ml or 20 ml ang usa ka vial. So magkuan ka kaduha ka mag-withdraw, no? So dako niya. Kuha na siya thick, no? Kaya mas sugar mo siya. So inikuha nimo mo taas lagi ang blood sugar lagi. Now let's check number 8. The key to identifying hypoglycemia is the presence of acidosis. True, false, maybe, I don't know. the key to identifying hypoglycemia is the presence of acidosis, is it? Number 9, any abnormal behavior in patients taking insulin should be considered a hypoglycemic reaction until proven otherwise. Ang sama, pasyente kay, lain ako pamati. So, sa may buhaton, what do you check? The 6 vital signs, right? Do you consider it as abnormal in patients with hypoglycemia or hypoglycemic reaction until proven otherwise? A, B, C, D. True, false, maybe, and I don't know. Number 10. A hypoglycemic patient will have positive serum ketones. A, true, B, false, C, maybe, I don't know. Okay, write your answers to a separate sheet of paper and then transfer it to the stream. I'll provide later. So let's move on to the next topic, DKA. So DKA, it's a very serious metabolic crisis that can result from hyperglycemia in patients with uncontrolled diabetes mellitus. Most frequently seen in adolescents and older adults with type 1 diabetes. Results from a deficiency in insulin leading to 4 life-threatening metabolic derangements. First one is hyperosmolar state. So a hyperosmolar state occurs because there is no production of insulin. The beta cells causing existing hyperglycemia, which causes a hyperosmolar state. Okay. Next is fluid shifting. So the hyperosmolarity results in shifting from inside the cell to the serum, and electrolyte shifts. So remember katong mga say insulin and friends, di ba? Ano na insulin, glucose and friends. Kung na si insulin kay manood sila, masud sila. Kung wa si insulin kay sila kasud sa cell. And something yung mga friends, si phosphate, magnesium, si potassium, no? So and then dehydration. So DKA may cause a patient to become dehydrated, and these are life-threatening. Anong life-threatening man kung mahurot imuhang or mawala imuhang potassium, because absence of potassium can cause fatal problems. Ato nang gidiscuss atong cardiology last time. And also fluid shifting, okay? So, mao na kung nami pasyente nga DKA, makanungog mo nga mo-order ang doktor og ato ni shift. So tagaan ka inon ka sa doktor nga tagaon ka og regular insulin unya og D50 nga IV, no, D50 dextrose in 50%. So hatag mo aron mo shift aron ang potassium mo unsa man taas mo ubos ana sud ang potassium sa cell, musud ang glucose sa cell, okay? Lifespan of patients with DKA is 15%. Of type 1 diabetic patients may die after the age of 40 years. Can you imagine? Type 2 diabetes insulin deficiency can contribute to the development of DKA. So, most probably type 1 ang magka-DKA, but in type 2 diabetes, pwede siya mo cause, especially kung nuna na yung resistance to insulin ang pasyente or nakalimot ang pasyente o hatag sing kagalingon og insulin. Okay? Other metabolic derangement brought by DKA occur because there's no insulin that exists. And to allow glucose to get inside the body, and therefore cells begin to break down fats and proteins to be used for fuel. So always remember, our body uses food as fuel, carbohydrate as fuel. Kung wala na sa blood, wala na detect ang body nga wala. In case of DM abnormal, detect siya wala. Yan nang i-consume ang imuhang first imuhang fats, and then imuha dayon mga proteins. Okay, this process causes the formation of ketones, and ketones decrease the blood pH and the bicarbonate concentration, causing a ketoacidosis. Mga pasyente na ketoacidosis, sinigsimot nimo sa ilang nasa cosmos breathing, so fruity ang ilang breathing. So this is a pathophysiology of DKA. So mo na ni ang so first kay pen. So first here, so now decreased insulin reserve. So increased muscle protein breakdown, mahitabuan og increased fat destruction. Okay. So after that, there's increased plasma amino acid levels, and increased fatty oxidation. Okay, so also here decreased glucose utilization and accelerated hepatic glucose utilization, causing hyperglycemia, osmotic diuresis, dehydration, and hypovolemia. So all of which will go to a process called ketosis and metabolic acidosis. So mo ni production sa imuhang ketones, unya ang imong blood kay kuan, imong body kay will become acidic, no? So metabolic acidosis mo na problema sa pasyente nga na ay DKA. So DKA clinical manifestation is a patient having glucose level of 250 mg per dl and elevated BUN, blood urea nitrogen, and also pH less than 7.25. So the lesser the number, the acidic it is. That is acidic or basic acidic. Bicarbonates, so less than 15, and significant anion gap is greater than 20 MEq per liter. Patient may have glycosuria and an osmolality level of greater than 300, and hyperkalemia is 5.4. So remember, sa cell, mauni ang cell, in order nga makasod ang imuhang glucose and friends, insay kalato ang friends, si potassium, si magnesium, si phosphate, no? Ang makasod sila, ginhanglan sila og ginsaman, ang key si insulin. Okay? Na mo na yung key, ang makasod siya, may mo-open sa door. No, kung wala ning insulin, wala pud na, so managhan sila diri. So ang key, managhan sila sa gawa sa cell, no, dili sila ma-metabolize. So mo na nagtagitawag hyperkalemia. So aron ma-correct ni siya, ang ilang buhaton sa mga doktor kay mo-order sila shifting. So shifting is the administration of regular insulin, okay? Regular insulin o D50. Anong tagaan man og D50? Anong tagaan mag regular insulin? When you give regular insulin, it provides the glucose and friends to get inside the cell. Okay? Anong tagaan mag D50? Aron dili unsa may problema kung ang glucose maadto na inside the cell. Kung kani maadto na sila inside the cell, potassium maadto na. Mo decrease na ang unsa man glucose levels. Hypoglycemia prevents hypoglycemia and prevents hypokalemia. So this is to correct the shifting, is to correct hyperkalemia. So if you have a patient with DKA, make sure nga na ay duha ka IV ang pasyente, large bore IVs. Can DKA occur in type 2 DM? Ako nag-answer ganiya, yes. Most frequently, it is the initial presentation of undiagnosed diabetes type 1, or can appear when patients have missed or reduced insulin doses. Clinical manifestation still, glucoregulatory hormone excess at levels enough to cause hyperglycemia during illness, stress, growth spurts, and pregnancy. Also remember that during illness, mutaas ang imuhang sugar levels. So medication causing insulin interference, thiazide, okay, dilantin, sympathomimetics, albuterol, dobutamine, dopamine, epinephrine, no, norepinephrine, phenylalanine, and glucocorticoids, dexamethasone. So always remember, class, if you give a patient dexamethasone or prednisone, always check blood sugar. Okay, why? Because they interfere insulin, therefore causing hyperglycemia. Hallmark symptom of DKA is ketosis, metabolic acidosis, and ketonuria, KMK. No, that's same gina hinumduman katong ng KMK katong sakyanan sa unang aircon sa Cebu, no? KMK man to. Other clinical manifestation are the following: weakness, anorexia, vomiting, abdominal pain, altered mental status, tachycardia, orthostatic hypotension, poor skin turgor, dry mucous membranes, and cosmos respiration. So, katong cosmos respiration ako nang mention is it is the body's attempt to eliminate ketones through respirations, giving the breath of a fruity, sweet flavor. No, nandito ni kanon kay fruity and sweet flavor man. Now, diagnostic findings for patients with DKA is serum glucose levels greater than 250, often more than 500 milligrams per dl. Glycosuria, increased serum osmolality, serum acidosis, elevated blood urea nitrogen, and initially a hyperkalemia. So, mo to is shifting ang pasyente. We call it shifting. I don't know kung si tawagan na sa Pilipinas, shifting. So, ingong shifting, makatag din ko o kuan. Regular insulin, i-order nila ang pila ka units, and then D50. Now, how to compute serum osmolality. So, normal serum osmolality for patients kay 280 to 300. An ion gap is 8 to 20. An ion gap is 8 to 20 milliequivalents per liter. So remember, nag-istorya tag an ion gap, nag-istorya tag serum osmolality. So this is how to compute them. In Canada, o uban nga country, or even sa Philippines, di na kami still pa mo kwenta sa serum osmolality o an ion gap. But just in case, pakwentahon ka kay kwan. So what is serum osmolality? Serum osmolality is the concentration of solute particles in blood. Can be calculated by using the serum measurements of sodium, glucose, and BUN. On the other hand, an ion gap is a calculation of the difference between the major positively charged electrolytes cations and the major negatively charged electrolytes in the blood. Helps determine the cause of metabolic acidosis. Now, what are the causes of DKA, initial presentation and diagnosed type 1? I think I mentioned this already. Missed or reduced insulin doses, illness, particularly infection and stress hormone in excess. Stress, mo pa stress, especially kamo kay mga batan pa kayo mo pa stress kasi inyo magka-DKA mo. Naamoy insulin. Ako naamoy type 1. Pregnancy and medications according to Schumacher and Czerny. Now, first line and initial treatment for DKA. So, So, closely monitor blood glucose levels and acidosis, arterial blood gas levels. So, last time, nag-student tag EBG and tanaw yung additional video about EBG. Administer insulin. Okay? And replace fluids and electrolytes. Monitor cardiac, pulmonary, and neurologic systems. And identify and correct precipitating event and educate the patient and family about what? About, istorya na ko na after this, kaning mga pasyente nga na ay DKA kay pwede silang makoma immediately. No? So muna, careful kaning mga pasyente ha. Medical interventions and nursing responsibilities. Monitor serum glucose levels at least every 2 hours, especially when patient is receiving continuous insulin infusion. So the only insulin that can be administered via infusion is regular insulin. Okay, administer rapid acting insulin if required. So replace fluid and electrolyte deficits, NS 0.9%. Kasagaran na mong gamiton. Initial is rapid, then if BP is normal, a hypotonic 0.45%, NS can be used. So monitor acidosis through ABG. So ito pasyente na DKA, metabolic acidosis. So acidosis is treated with bicarbonates, okay, when the serum pH is 7.1 or less. So karon kay bagong technology na sa una kay magkwenta-kwenta pa yung karon bagong na technology, ihatag na nila tanan. So monitor cardiac, pulmonary, and neurologic status. Monitor and correct electrolyte imbalances like potassium, chloride, phosphate, and magnesium may be required. So magkuan mo shifting, no? Tagaan ninyo sa tagid ihatag sa shifting, regular insulin and D50. Okay, potassium replacement if no contraindication begins with fluid therapy. Monitoring of potassium during treatment is mandatory. So included na siya, no? Sa imong monitoring. Observe for ECG abnormalities, no? So man yung mga ECG abnormalities, ST depression. So ST depression, remember we talked about this last time. ST depression is hypo-K, signs of hypo-K. Widened QRS and tall QRS, peak T waves is sign of hyperkalemia. Okay? So, na siya mga indicators. So, muna nga. So, ito nyo pagbutang og ECG. Nakahindom pa mo sa pagbutang sa ECG o tele. No? Ayaw na ninyo claim team. Ako suggestion nyo, ayaw nyo claim team saan pagbutang ang ECG o ang telemetry. Okay? Kung nakalimot mo, review my previous video. Correct sodium levels with volume replacement of normal saline, 0.9%. Correct infections, if any, WBC greater than 25,000 with more than 10% neutrophils. No? So, kung makita niyan ninyo na ay infection, automatic din na siya. Kay DKA could be stimulated by or aggravated by infection. Provide patient and family support and education to prevent further episodes of diabetic crisis. Why? Because they don't like the diagnosis, no? It's like ginahan mag-control sila, mag-check silang blood sugar. It's like ginahan mag-control silang blood sugar. Mao na mag-end up sila sa hospital having DKA. Okay? Provide patient family support and education to prevent further episodes of diabetic crisis and emphasis on glucose monitoring and regulation, eating schedules, diet, exercise, and rest. So, ang pasyente ani from, like, unsa dyan dagwa ang pasyente nga nag-DKA? Like, masige na sila suka, masige na sila weak ilang pamati, sick ilang pamati, no? Nya, human kay kuan, ang mahigdaan na sila, matug, nya, matug, makuma. So, mao nang inyong timan-an sa mga patient nga DKA. Life-threatening ang DKA. So, to correct sodium levels in hyperglycemia, add 1.6 MEq to measure sodium for each 1,000 mg per dl of glucose above a serum glucose level of 100 mg per dl. So, dili kinahanglan observe, ako itong isulti just to, like, FYI ba, pero dili na necessary. Isulti lang i-order na sa doctor niyo. Complications of DKA is hypoglycemia. So because of over-aggressive treatment, no? Daghan nagpahatag og kuan, shifting. Next is hyperglycemia. So interruption of IV insulin with other coverage mo na nga may duha ka IV sa pasyente nga na ay DKA. Kay mangusa maghatag og insulin, ang usa maghatag og antibiotics or whatever. So uban mingon na pasyente nga I wanna go to the washroom, patangtang ang IV. Kung na-game may pasyente na ayaw yung magsugot kay ngano, end up mag-hyperglycemia, makuha ng pasyente. Coma. Hypokalemia resulting from insulin administration and treatment of acidosis with sodium bicarbonate. So mag-hypokalemia. So remember, ang pasyente nga na DKA, nag-hyperkalemia na sila. Kay wala naman, si glucose and friends di makasud, kay wala si insulin nga mao ang key, nga makasud sila sa cell. No? So, may tabo, kaya ito naman itagag insulin, nisod na si glucose and friend. Nahurot na, nabutang na tanan, nag-manufacture, kuha na metabolize na tanang potassium. So, hypokalemia ang pasyente. So, mga na siya. Okay? Complications, hypoglycemia, hyperkalemia, o hypokalemia. Hyperglycemia, o hypokalemia. Knowledge check. So after reviewing the following results of a patient's physical examination, calculate serum osmolarity and anion gap. A 29-year-old woman has a 4-year-old history of insulin-dependent diabetes. A recent episode of influenza has led to her admission to the intensive care unit ICU. A physical examination reveals the following: respiratory rate 40, respirations deep and rapid, heart rate 118 BPM, BP 88/50 millimeters mercury, temperature 38.8 degrees Celsius, orally lanat. Skin dry, poor, with poor turgor, patient is lethargic but responsive to simple commands. Admission, laboratory data, serum glucose 540 milligrams per dl, BUN 70, hemoglobin 14 grams per dl, hematocrit 48, serum sodium 129 MEq per liter, serum potassium 5 MEq per liter, serum chloride 94 MEq per liter, pH is 7.23, PCO2 is 22, HCO3 bicarbonates is 8. So, what is the serum osmolarity? So, you go back to my previous slide to take a look at the formula and calculate the serum osmolarity. A, B, C, or D. Okay, that's question number 11. Question number 12, what is the anion gap? A, B, C, or D? Just to do an exercise in hospital, dili na mo magkwinta-kwinta. Wala mo time sa emergency department, wala na mo time to calculate. Okay? Computerize na natanan. Our next topic, I think this is the last topic for this unit, is hyperglycemic hyperosmolar non-ketotic syndrome, or HHNS. It is a serious metabolic complication of diabetes. Okay, so it is also known as hyperglycemic hyperosmolar state, or HHS. Usually seen in patients with type 2 DM. In type 2 DM, the problem is relative insulin deficiency. So type 2 napay gamay nga insulin. Type 1 wala na gyud insulin. So this one napay gamay nga insulin, and the cells are able to use some glucose. However, there is not enough available for cellular metabolism because of the insulin deficiency, so hyperglycemia develops. This causes cellular dehydration, osmotic diuresis, and fluid and electrolyte disturbances. So, but ketosis and acidosis are minimal or absent in hyperglycemic hyperosmolar non-ketotic syndrome, or HHNS, or otherwise called as hyperglycemic hyperosmolar state, or HHS. Okay, these patients are very dehydrated, so that's the problem with this patient with blood. So parihara siya og symptoms sa DKA pero walay ketosis, walay acidosis. Okay, patients are hydrated with glucose levels typically exceeding 600 mg per dl or greater. Marked hyperosmolarity and elevated BUN levels also exist. Okay, usually occurs in type 2 DM. Patients who have omitted or reduced their hypoglycemic agents. Other than that, other causes include drugs, enteral feeding, hyperalimentation, and peritoneal dialysis. So DKA is for DKA kay kuan siya caused by type 1 diabetes, but mukor po siya sa type 2 in some situations. Okay, tarong administer siya ang insulin, but this HHNS occurs in occurs in type 2 diabetes. Okay, so let's start. Here I have here a diagram, pathophysiology of HHS by Sweet and Foley. So what you see in here is a decrease in insulin reserve. So ang mahitabuan na the body then breaks down what? The protein, which increases the plasma amino acid levels. And then accelerated hepatic mahitabo sa na after decreased insulin levels, there is a decreased glucose utilization and accelerated hepatic glucose utilization. Remember glucagon? So mo na breakdown causing hyperglycemia. So simple kaayo, no? Like sa subton, osmotic diuresis, dehydration, severe hypovolemia, which creates perineal azotemia, hyperviscosity, and thrombosis. So sufficient circulating insulin to inhibit lipolysis, which averts the onset of ketoacidosis. Okay, walay ketoacidosis kay naamay sufficient insulin lipolysis. Okay, so this is a comparison of classic presentations of ketoacidosis, DKA, and hyperglycemic hyperosmolar state. So patients age for DKA, they are usually the younger, right? HHS, usually older adults. Okay, type of diabetes, type 1 is DKA, type 2 is HHS. Duration of symptoms, hours to days. HHS is several days. Neurologic symptoms and sign, rare except complication, and neurologic symptom for HHS is very common. Glucose levels greater than 250 mg per dl ang DKA, and ang HHS is 600 mg per dl. Ketones, moderate to large. HHS is small or absent. Mo characteristics sa HHS, wala siya ketoacidosis. Serum sodium likely to be low or normal for patients with DKA, and remember you have to treat this with 0.9% sodium, and HHS is low or normal. Serum potassium, ang DKA is high, normal, or low. So high when insulin is not given, low when it's given. Okay, high, normal, or low HHS. Okay, serum bicarbonate, low, and in HHS, normal. Mga tagaan mo bicarbs ang pasyente nga na DKA. Blood pH is low, acidic, and HHS is normal. So man wala acidosis. Serum osmolality typically normal, and sa HHS is greater than 320 milliosmoles per liter. Thrombosis in DKA rare. In HHS there is likelihood of thrombosis. So on the slides in front of you, naatay symptoms sa tulo. Akong i-compare ang tulo. Compare na ko ang tulo, DKA, HHS, and hypoglycemia. So ang pasyente nga na ay DKA will present to you with confusion, lethargy, warm, dry, flushed skin, weakness, nausea, anorexia, and abdominal pain, tachycardia, fruity acetone breath, and deep rapid respirations, Cosmos breath, okay, and thirst. Okay, patients with HHS will present to you almost the same. Okay, weakness, tachycardia, rapid respirations, but there is no acetone breath. Okay, wala acetone breath. That differentiates from that. Ano siya ng kalain niya sa DKA. Next is hypoglycemia. So patients with cold, clammy skin, pallor, profuse sweating, normal mucous membranes, irritability, tremors, poor concentration, tachycardia, bradycardia, in coma, normal rapid respirations, acetone breath, and hunger. One is hypoglycemic. Unsa may problema kung ang problema kung mag-hypoglycemia po siya pag mag-coma. Ganun isang DKA, pwede po mag-coma. Okay? Hindi mas treated. So, blood glucose for patients with DKA, 300 to 800. Ang HHS is 600 to 2000, and hypoglycemia is below normal. What is normal? It's 80 milligrams per DL or below 4 millimole. Ang gamit sa Canada kay millimole. Ang gamit sa Philippines o United States is 80 milligram per DL. Serum sodium for DKA patients normal to decreased. HHS is variable. Hypoglycemia is normal. Serum potassium for patients with DKA variable or low, variable or elevated for HHS, and normal. Serum osmolarity elevated for patients, but usually less than 330 milliosmoles. Okay, significantly elevated for patients with HHS. Ang iyang osmolarity for patients with hypoglycemia is normal. Arterial blood gases, metabolic acidosis with compensatory respiratory alkalosis. Metabolic, always remember that patients with DKA always have metabolic acidosis with compensatory respiratory alkalosis. HHS is normal to mild acidosis. Hypoglycemia is normal to slight respiratory acidosis. Serum ketones, positive for DKA, muna siya na characteristics niya, and then negative for both HHS and hypoglycemia. Urine, positive for glucose, for ketones, and HHS, and hypoglycemia negative. Interventions for DKA, administer insulin, fluid, and electrolyte replacement. Okay, and for HHS, insulin, fluid, and electrolyte replacement, and for hypoglycemia, glucose and glucagon. Okay, o pagkaon, gutom. Next is next is clinical manifestations. So clinical manifestations are profound dehydration. So for HHS, profound dehydration, hypotension, tachycardia, diminished central venous pressure (CVP), dry mucous membranes, and poor skin turgor, and neurologic impairments including confusion, seizures, and coma. So mao na inyong timaan for HHNS. Makakos po siya coma. So mahadlok ta na kita niyo pa siya ng dayo nagkatubig ng mata. Kuyawan ako ana, no? So, early detection ginin yung buhaton. History taking. May pasyente na ako diabetes. Ang question yun din mo, nainom kasi muhang oral anti-hyperglycemic or nag-inject ka kung type 2. Type 2. Okay? Next. Hyperglycemic, same thing, treatment. So, nasa diri ang akong blood glucose indicator card kay duha man ka systems akong gamit diri no. Sa Canada is the millimole, sa Philippines ug US kay ang milligrams per TL. So treatment, that the goal for treatment is similar to the interventions for DKA, for HHNS or HHS. Rapid treatment of fluids to correct dehydration, which is very important. Always remember this. Physicians use isotonic fluids to replace half of the estimated fluid deficit within the first 12 hours and remainder within 24 hours. Nurse to monitor serum potassium levels closely, okay? Because patient is hyperosmolar, dehydrated, and depleted of potassium intracellularly. Rehydration of replacement fluids alone can decrease serum potassium levels. Flash out na sila. Insulin therapy causes potassium to move into the cell along with glucose, further decreasing serum potassium levels. Fast-acting form of insulin is typically administered by IV and close monitoring blood glucose levels. When blood glucose levels approaches 300 milligrams or 16.6 millimole, addition of dextrose into the IV infusion should be considered because the blood glucose levels can drop and the patient can become hypoglycemic. Monitor cardiovascular and neurologic status, LOCs, yung mga coma man. Remember that HHS and DKA are precipitated by underlying status like infection, infection or gisipon. Patient and family education to prevent future occurrences. Tuduan mo sila on how to do blood sugar test, how to monitor their food intake, exercise, Knowledge check. After reviewing the following results of a patient's history and results of laboratory studies, this is provide your answer to the following questions. ML is a 76-year-old woman who lives alone. Her medical history includes twice daily diuretics for the treatment of hypertension and a present complaint of thirst and urination over the past month. Her daughter took her to the emergency department because she was lethargic and difficult to arouse. Her skin and mucous membranes appeared dry. She was in a sinus tachycardia. Laboratory studies disclosed the following values: blood glucose level 1230, sodium 144, serum potassium 5.5, BUN 79, creatinine 2.8, serum osmolarity 361, pH 7.35, its CO3 18 milliequivalents per liter, urine positive for glucose, serum and urine ketones negative. Question number 13. Is ML more likely to have DKA or HHS? A. DKA because the laboratory values reflect a glucose level of greater than 1000, acidosis is present, and no urine and serum ketones. So your knowledge on the signs and symptoms of DKA and HHS will work in here. B. HHS because laboratory values reflect a glucose level of greater than 1000, no acidosis, and no urine and serum ketones. C. DKA because laboratory values reflect a glucose level of more than 1000, acidosis is present, and presence of urine and serum ketones. D. HHS because laboratory values reflect a glucose level of greater than 1000 with acidosis and presence of urine and serum ketones. A, B, C, or D, number 13. Number 14. What are some important nursing and medical intervention for patient ML? A. Needs IV replacement of fluids. B. Needs rapid-acting insulin. C. Close monitoring of serum electrolyte. D. All of the above. 15. Number 15. Knowledge check. To correct low sodium levels for patient with DKA, the nurse would expect an order for volume replacement with A. Normal saline. B. Lactated ringers. C. D50. C. D50. D. Insulin. Please don't forget to transfer your answer in the Unit 5 knowledge check in Google Class. And I think that's all for this unit 5. I think we discussed whatever is covered in our course outline, and thank you for listening. And these are my references that I use in this lecture. Once again, thank you so much and have a wonderful day.